Okay, well, hello everyone. Today I'm talking to Suzanne O'Sullivan, who is the author of The Age of Diagnosis. So thank you so much, Suzanne. Maybe you could start by just telling us a bit about your professional background, why you've chosen to write this book, and maybe what some of the main questions were that you were trying to address.
Yeah, so I'm a consultant neurologist. I've been a doctor for since 1991, and I have been a neurologist since 2004. And basically, I wrote this book because, I am a doctor who's seen patients for a very long time. I have a lot of clinical experience, and I've really found over the last sort of 10 or so years, probably 15 years, that I've increasingly seeing lots of very young people, so people say in their 20s, in their 30s, who have long lists of medical diagnoses. And it doesn't always feel like those medical diagnoses are getting them anywhere. In the old days when I qualified as a doctor, the purpose of a diagnosis was to lead to support, treatment, and hopefully improvement, if not in the symptoms in life. But what I began to sort of feel in recent years is that people are accruing diagnoses that aren't actually making them any better. So I wrote The Age of Diagnosis really to get a sense of how diagnoses grow and spread and to really get a feel for whether or not this kind of perception of my own that there's kind of widespread overdiagnosis is upheld by the science.
Hmm. Hmm. And you speak about the differences between overdiagnosis and over-medicalisation and the kind of mechanisms behind each of those. Could you tell us a bit about that?
Yeah, so I think it's important for people to understand. I think when people hear, especially politicians, talking about things like overdiagnosis, they think that what's being said is there's nothing wrong with you, that it's that overdiagnosis is easily kind of mixed up with misdiagnosis. Overdiagnosis doesn't necessarily mean a diagnosis is wrong. It doesn't necessarily mean a person isn't struggling. It's just overdiagnosis means that a diagnosis might actually be doing more harm than good. So perhaps what one gains from a diagnosis through treatment and validation might be outstripped by the harm of a diagnosis in terms of treatment or labeling, for example. And overdiagnosis kind of comes in lots of forms. Sometimes it comes around because we decide we're going to, as scientists and as society, look more closely at people to find diseases in earlier and milder forms, on the assumption that if treatment and diagnosis helps people with severe disease and illness, it will equally help people who are less severely affected. It also comes about because we get better technology that allows us to find things that we couldn't find 10, 15, 20 years ago. So in lots of different ways, diagnosis of both physical health and mental health conditions are spreading and increasing in numbers. And I think, my worry is that although that was all very well intentioned and the idea is that we make people better, I'm not absolutely convinced it's working.
Hmm. And what are the biggest markers you found, over the course of your research that we might be in an area of overdiagnosis like that?
Well, you see the signs in both physical health conditions and in mental health conditions or behavioral conditions or learning problems. So let's say in the case of something like overdiagnosis has been a concern for many doctors in the case of screening for cancer, for example, for a really long time, because there are studies that show that if you screen a lot more people for cancer, you will find a lot more cancer cells. And what that should mean is that if screening and finding these early diagnoses were working and you treat them, then in the population, you should be seeing fewer people with late stage cancers. But actually, we're not really seeing that. We've got a whole new population of people with very, very early cancers, pre-symptomatic, no symptoms, perfectly healthy people diagnosed with cancer on screening. This is a new population, but we also have a growing population of late stage cancers. And this is kind of what happens with overdiagnosis. If you find lots of things in really mild forms, you're potentially treating people who didn't need to be treated. That's why you're not seeing the downstream improvement. I would say we're seeing a similar effect in, say, the expansion of the diagnosis of something like autism. So for years, children struggling in school were neglected. When I was in school, nobody was recognized as having a special learning need, but there must have been people who would have benefited from support. So we had a sort of chronic neglect underdiagnosis problem. So we relaxed the criteria of what it means to be autistic, and we looked more carefully for people for milder forms of autism. The idea there is that you then give people support in childhood and that they will benefit from that in adulthood in some sense, in improved mental health, improved relationships, in improved functioning in the world. But what we're actually seeing is that in childhood, the numbers of people with autism have risen from something like 1 in 2,500 children to 1 in 100 children worldwide, 1 in 36 in America, and 1 in 20 in Northern Ireland. And in schools, we've gone from no special accommodations to 27% of kids in the UK getting special accommodations. But we're not seeing the downstream improvement in these people's well-being. We are also seeing more people with mental health problems in young adulthood. So I think it's very well intentioned to try and find more people with special learning needs, but it doesn't seem to be working. We are having no improvement in functioning relationships or mental health of young adults as a result. So I think it's time to kind of stand back and say something is going wrong. That cannot be right. We should be seeing some evidence that this is working, and I see no evidence that it's working.
Hmm. Is is this an issue of the support available not being kind of right or sufficient, or are you saying that more your concern is that having the diagnosis itself, when it's if you have milder traits or symptoms, may actually do
Yeah.
harm in terms of the person's experience?
Yeah, I think people will argue and say that it's because the help isn't good enough. But I think you have to, and I wouldn't disagree that, perhaps the support isn't right or that or we're not doing the right things. And I don't disagree with that. But if you've gone from zero special accommodations in school to 27% of special accommodations in school, and you are not seeing any improvement, then you have to wonder, it's not that the special accommodations or support, it may well that needs to be improved. But, that's a pretty big shift from nothing to a third of kids getting support. If that isn't working, then either the support that we're giving is completely the wrong support. So it shouldn't be extra time in exams, or again, I don't know the answer to this necessarily, but either the support is completely wrong, or, and this would be my suspicion and my concern, is that, if you take a teenager or a young person at the mild end of a spectrum. So I'm not talking about moderate or severe problems in the domain of autism or ADHD. Those problems are disabling in themselves. But at the very milder end of the spectrum, when a child's brain is still maturing and has time to sort of socially compensate over time for some of these difficulties, the worry would be that that label has a very negative effect on that young person. My concern is that we're taking a bunch of young people and asking them to focus on the things they can't do and worry about the things they can't do, and that we are potentially making the difficulties that they have in their life seem concrete by labeling them as neurodegenerate or as not neurodegenerative, as neurodevelopmental problems, and that we are kind of creating a self-fulfilling prophecy in children. I mean, what happens to a child if you tell them that they have a neurodevelopmentally abnormal brain that means they can't communicate as well as other people, or they need a different style of learning? Is they may inhabit that identity, unintentionally. I don't think it's any different. We've all had experiences when in school when you're known as the clever one or the not so clever one or the arty one. It's very easy for a child to inhabit those identities that they're given in school years. So one possibility is that the support we're giving is all completely wrong, but I think a big contributor is that we are labeling children and that they are conforming to those labels.
Mm. Yeah. I mean, the conversation about children and adults obviously seems different, and there's been a massive increase in adults being diagnosed with autism and
Yeah.
ADHD. I mean, how does, yeah, what are your thoughts on that situation, and how does, adults being diagnosed in the milder side have that impact on the
Mm.
severe ends or on children, if
Yeah,
any?
I do think it's the conversation between adults and children is different, because obviously an adult has at least had the opportunity to form their identity and discover what their strengths and weaknesses are prior to the diagnosis. I think the difficulty with, again, I know people won't all agree with this view, but I think, if an adult has got to adulthood and formed relationships and had a job, they may well have struggles, but I'm not sure it's beneficial to the autism community at large to label those struggles as autistic. I'm not advocating for saying that if someone's now in their 30s and they realize that they have a difficulty and they would like extra support, that they shouldn't be able to go to someone and get support. But I think that if your autistic traits haven't been prominent enough to affect your life to the degree that you cannot do ordinary normal things, then it's perhaps counterproductive to the community to refer to that as autism in the same category as the type of autism that affects children in the more moderate severe category. Because what you get then is you get this incredibly heterogeneous pool of people who all have phenomenally different levels of function and phenomenally different difficulties, and they are competing for the same resources, and that's a very big problem. But it's also very problematic for the research world of autism if we are including people who have the level of function where they can have relationships and jobs and survive through life without people realizing that they had this diagnosis, and you're putting them in the same research group as a child who couldn't possibly stay in school if they didn't have the support to keep them there. I think if we ever want to really understand how to help people with autism and the underlying causes for autism, we're not going to find that as long as we allow the group to expand to this extent.
Mm. And do you think there's a similar thing happening in terms of more common mental health difficulties like anxiety and depression?
Yeah, I do worry that, we've had again, I fear we're overcorrecting an under diagnosis. We have a history of neglect. Again, if I go back to when I was in school or when I in my early years in college, say, you know, people didn't really talk about having mental health problems, and people didn't really feel comfortable necessarily coming forward. And I think we definitely needed to do something about that. But I fear that we have gone too far again, that we've overcorrected. I think with every mental health awareness campaign and every celebrity that comes forward and says they have a mental health problem, we are helping some people and we are potentially encouraging other people to worry about things they wouldn't have worried about before the awareness campaign. So we all feel low sometimes. Low mood usually resolves spontaneously, within a month or two, doesn't necessarily need to be medicalized at that level. But I think the way we talk about mental health now is we're encouraging people to worry about symptoms that they perhaps would have worried about less before, or perhaps these are symptoms um, that they should worry about and that they should seek support for, but by giving labels at the very milder end. Again, we're into the category of once you tell someone they have depression, they are a person with depression rather than a person who's going through a transient period when their life is difficult and they're responding psychologically in a certain way. So I think we are a little bit too eager to give medical labels to suffering, and that we are also worrying people by uh, perhaps some over exuberant awareness campaigns.
Mm. I thought what was really interesting in your, well, part of what was very interesting in your book was the research around this not actually being necessarily just an issue of kind of mental health conditions where subjectivity is at the center, but actually that with physical health conditions as well, that there can be a
Yeah.
negative impact on the individual if there's an over identification or over absorption of that condition into their identity.
I mean, that's the thing. When you talk about overdiagnosis and expanded disease categories, everyone always thinks mental health. But this is a problem in every aspect of medicine, actually, because we are, this is what we do now in medicine is we have a real active way of looking for diagnosis in earlier forms and in milder forms. It's a really it's based on really good assumptions. The assumptions seem really sound, which is, for example, if you can find as many people with borderline hypertension as possible, you'll prevent a few strokes. And therefore, for many years, they have been gradually edging down what it means to have high blood pressure. And there was one of those changes when blood pressure went from 140 over 90 to 130 over 80 being the cutoff for normal. It immediately meant that a third of adults in the UK would be diagnosed as having borderline hypertension. Now, the purpose of that is to prevent strokes in some of those people, and it will prevent strokes in some of those people. But the number of those people who are going to have strokes is really quite small. And what we never talk about and we never think enough about, in my opinion, is that, if you prevent a stroke in one person and you have to treat 99 other people for hypertension, what's happening to those other 99 people? Now, some will say, hey, if the only thing they have to do is, cut salt out of their diet and do sensible things, maybe it's not that harmful. Um, but what that doesn't kind of allow for is what happens when you tell a healthy person that they're a patient and you compel them to start going to the doctor regularly and you make them more conscious and aware of their bodies. That sort of, the impact of telling a healthy person that they now have a medical problem is something I don't think we give enough thought to. We concentrate very heavily on in a cancer screening program. If you screen 2,000 women for cancer, you will save one life from cancer and you will treat 10 people for cancer who didn't need to be treated. Now, we think a lot, we all think about the life that was saved, and we're not thinking enough about what is the psychological, financial, social impact on those other people. Because even things like your health insurance, or your health insurance goes up, your travel insurance goes up, applying for life insurance or mortgages can be affected. It changes how you think about and how you see your body.
Yeah.
These diagnoses have implications that I don't think we talk about nearly enough.
Yeah, it seemed to me reading the book that quite a lot of it hinges on whether or not you're willing to accept the way that the mind and body
Yeah,
interacts together, and
yeah.
whether or not you're willing to kind of accept just how intense that connection can be and what the consequences are. I mean, can you tell us a little bit about what you see as the main misconceptions are about psychosomatic illness?
I mean, of course, that's you're quite right. I mean, and that, of course, is where my interest arises of it, because as a doctor, I'm a neurologist and I look after. My clinic is for people with epilepsy, but about depends on the month, but let's say, a third to a fifth of people in my clinic at any particular time don't have epilepsy. They have seizures that are purely psychosomatic in origin. So I see this all the time. So I know how incredibly strong how your perception of your body is changed so easily by small things, and I know how wrong that can go. Unfortunately, I think a lot of people think about psychosomatic symptoms. So when I say psychosomatic, I mean, real physical symptoms that can be extremely disabling, but that don't have an underlying disease process causing them and are likely to have a psychological cause. I think when you talk about psychosomatic symptoms, people immediately think, oh, they're less severe. It means there's nothing wrong with you. It means that you could snap out of it, or you're doing it on purpose. There's so many misconceptions around this. But psychosomatic symptoms are some of the worst and most disabling disorders I see in my practice. People with seizures and paralysis and blindness. I'm not suggesting that, labeling lots of people with hypertension is going to lead to that extent of psychosomatic illness, but rather trying to illustrate to people how serious psychosomatic symptoms can be. I try to tell people that our bodies are integrally related to what's going on, and how our bodies feel is integrally related to what's going on in our environment and our psychological well-being at all times. And I know it's hard for people to appreciate that, so I try to give them examples and just remind them that not every footballer can take a penalty, because a percentage of footballers just they lose all coordination as soon as there's a scrutiny of a crowd. The entire um, coordination of one's body and one's kind of fluidity of your motor movement is affected by the scrutiny of others. I try to remind people that you can't, we're not aware of our bodies most of the time if we're perfectly healthy. But if I now ask people to think, to start paying attention to their hand and to think about it, they'll immediately notice that their hand feels different. So this sort of, when you are scrutinized, or when you scrutinize your body, it changes your entire relationship with your body. And that's normal. That's physiology. That's the nature of the mind-body interaction. And that can go very wrong. And it doesn't take much for that to be provoked into disability. I start the age of diagnosis with the story of a woman who learns her mother has Huntington's disease, which is a genetic condition. And if your mother has it, you've got a 50-50 chance of having it. And she developed the absolute conviction that she had inherited Huntington's disease from her mother, but chose not to have the genetic test for quite a number of years, just because she knew that if she tested positive, it would mean her children could be affected, and she didn't want to, live with the consequence of a positive test. But because she had such a strong conviction that she had inherited the gene from her mom, she became quite disabled over years. It changed her whole relationship with her body. She was bumping into things. She got flustered. Her personality was changing. She became easily angered. And 20 years after her mother tested, she tested and discovered she didn't have the gene. And I start the book with that story because I'm trying to illustrate to people, if you believe you have an illness and you see yourself as not healthy, then that will, all our bodies are awash with funny symptoms and white noise and things that are available to be worried about if something directs our attention to our bodies. And, for her, the thing that directed her attention to her body was her mum's diagnosis. But I worry for a teenager, it will be because someone told them they have autism, or for an older person, it will be because someone told them they have hypertension. And I think we need to think about that mind-body interaction more carefully.
Mm. Thank you so much for your time, Suzanne. I know we have to end it there, but yeah, thank you so much, and wishing you all the best with the book.
Thank you so much. Nice to talk to you.
You too.